This recorded lecture will be going over Chapter 26, the sensory system, ear, in the MedSurg textbook. The meatus is lined with numerous hairs and glands that secrete a waxy substance known as cerumen or earwax. The middle ear contains the auditory bones, known as the ossicles, and it opens up into the eustachian tube. The eustachian tube connects the middle ear with the throat. The pinna collects sound waves and channels them into the auditory meatus. The tympanic membrane vibrates when sound waves hit it. These sound vibrations are then conducted to the malleus. The organ of Corti transmits impulses to the cochlear branch of the vestibulocochlear nerve. This is cranial nerve number 8. This nerve carries the impulses to the medulla oblongata, the thalamus, and then to the temporal lobe of the brain, which contains the auditory cortex. The eustachian tube helps equalize pressure in the middle ear. Receptors responsible for equilibrium or balance are located in the inner ear, within the bony vestibule, and at the base of the semicircular canals. Age-related changes in the ear. Cerumen becomes harder, containing less moisture, and its buildup within the ear could contribute to a hearing loss in the low frequency range. Cerumen becomes thick. The joints between the auditory bones become stiffer, and this stiffness can interfere with the transmission of sound waves, but it is not clinically significant by itself. The National Institute on Deafness and Other Communication Disorders reports that 24% of adults aged 20 to 69 in the United States are showing signs of noise-induced hearing loss, with those ages 60 to 69 having the greatest incidence. Approximately 2 in every 1,000 babies born in the United States will have some form of congenital hearing problem. After age 75, about 50% of the population will have some degree of hearing loss. On page 620 in the green health promotion box, you can read about coping with hearing loss. The sooner a person with a hearing loss obtains and learns how to use a hearing aid, the greater their hearing improvement will be. There are 2 types of hearing loss related to problems in the ear: sensorineural and conductive. Disorders of the hearing nerve, known as sensorineural loss, are the most common cause of hearing loss. Conductive hearing loss can be caused by a problem transmitting sound impulses through the auditory canal, the tympanic membrane, or the bones of the middle ear. You could also have both types of hearing loss. This would be known as mixed. On page 620, within box 26.1, you can see common causes of sensorineural and conductive hearing loss. Arteriosclerosis can cause a decreased blood flow to the vestibulocochlear nerve, resulting in sensorineural hearing loss. Hearing allows for communication with others in everyday conversations, within the classroom, and in business transactions. Because hearing warns one of danger, an inability to hear can lead to anxiety and fear. Inner ear disorders can cause problems with balance. Dizziness, vertigo, and ataxia can greatly interfere with an individual's ability to work or perform their usual activities of daily living. Adequate treatment of severe ear infections can help to preserve hearing. Loud noise is a major cause of sensorineural hearing loss, and the use of headphones or earbuds contributes considerably to hearing damage. A large amount of hearing loss results from employment-related exposure to loud and continuous noise. Hairpins, the ends of pencils, cotton swabs, or other objects should never be used to relieve tickling or itching in the ear or to remove cerumen. Obstructive cerumen should be removed by using ear drops that dissolve it, or by using ear irrigation devices, or by a healthcare provider or nurse who is skilled in removing the impacted cerumen. Conductive hearing loss most often occurs from stiffening of the bones of the middle ear or from scarring of the tympanic membrane. Continued exposure to excessively high levels of sound can produce sensorineural loss, known as noise-induced hearing impairment. Sustained exposure to noise levels above 85 decibels can result in hearing loss. The higher the sound level, the less time it takes to cause damage. Many drugs can also be toxic to the inner ear. Commonly administered drugs that can be ototoxic include many antibiotics, NSAIDs, chemotherapy agents, and potent diuretics like furosemide. Aspirin and other salicylates can produce a loss of hearing of high frequencies and a ringing in the ears. This is known as tinnitus. NSAIDs are more toxic in older adults and whenever used at maximum dosages over an extended period of time. The two instruments most commonly used to examine the ear canal and tympanic membrane are the otoscope and the oral speculum. The simple speculum can be modified by attaching a special tube and inflatable bag, known as a pneumatic otoscope. This creates an airtight system. This will allow the examiner to determine whether the tympanic membrane responds to positive and negative pressure. A normal eardrum will move in response to pressure. A simple hearing test is the whisper test. The examiner will stand behind the patient and whisper a question to the patient while having the patient place a finger on the tragus of one ear to mask the hearing in that ear. If the patient hears the question, an answer is forthcoming. The other ear will be tested in the same way. Tuning forks can measure hearing by air conduction or by bone conduction. This is known as the Weber test and the Rinn test. To test for nystagmus, this is the involuntary rhythmic jerking of the eyes, you should hold a finger directly in front of the patient at eye level. The patient will then be asked to follow the finger without moving the head. The patient's eyes should be watched for any jerking movements. Nystagmus, other than at the extremes of lateral gaze, is known as abnormal, and this can indicate an inner ear problem, an intracranial tumor, or paralysis of an eye muscle. The Romberg test is a test of equilibrium. The patient will stand with the feet together, the arms out to the sides, and the eyes open. You should note the ability of the patient to maintain an upright posture without swaying. If the patient loses balance, it could indicate a problem with the inner ear or the cerebellum. Patients older than 60 should always be assessed for hearing loss. Hearing and balance are subjective problems, and they will require a good history from the patient. Diagnosis of infection will require an otoscope examination. There should be no secretions in the ear other than cerumen. Lesions on the pinna can indicate skin cancer, particularly in older adult patients. On page 624, within table 26.2, you can read about diagnostic tests for ear problems. Many long-term care residents have a correctable hearing loss that can be related to impacted cerumen. When a patient is severely hearing impaired, communication with the patient for treatments and activities of daily living can take longer than with patients who hear normally. Always take this into consideration when creating your daily work plan. Interventions for patients with hearing or a balance problem will be aimed at patient education, treatment of infection, pre-op and post-operative care, measures for communication. On page 626 within box 26.3, you can read about some more guidelines or strategies that you can use for communicating with a patient who is hearing impaired. Eardrops can be prescribed to dissolve cerumen, relieve pain, or combat infection in the auditory meatus. The medication should be at room temperature because cold eardrops could lead to discomfort or dizziness. For adults and children 3 years of age and older, the ear canal is straightened by drawing the pinna up and back towards the head. For a child younger than 3 years, the pinna should be pulled down and back. If a patient cannot hear well and misunderstands or misinterprets voices and sounds in unfamiliar surroundings, they are likely to be frustrated, fearful, and anxious. When speaking to a patient who is hearing impaired, sit at eye level facing the patient. Gain eye contact and speak slowly and enunciate clearly. Past experience has taught many people with hearing loss that Asking for repetition of questions will irritate people and cause them to think that they are stupid. For this reason, many people who cannot hear well will commonly smile and say yes when an answer is either incorrect or inappropriate. A note should be placed over the terminal on the central nurses station intercom system that will designate the room of the system who is hearing impaired. Determining whether a patient's hearing has improved is the criterion by which effectiveness of treatment will be evaluated. Improvement can be verified by audiometry. Resolution of infection is determined by the appearance of the eardrum, absence of pain, and a normal temperature. On page 628 within box 26.4, you can read more about caring for a hearing aid. Hearing impairment ranges from difficulty in hearing certain ranges of tones or in understanding certain words to total deafness. Persons with sensorineural hearing loss will typically have more difficulty hearing high-pitched tones than low-pitched tones. Therefore, they can commonly understand the speech of men better than that of women. It is especially important to speak slowly and clearly and to face the person when communicating with them. Patients with sensorineural hearing loss will tend to speak louder than necessary. Hearing aids can help some people with sensorineural hearing loss. Hearing aids are not always the answer to a problem of hearing loss, and for some people, the most effective therapy will be focused on rehabilitation to facilitate acceptance of the loss and learning new ways to communicate despite some degree of deafness. Most hearing aids will function by air conduction. Many people will have a combination of 2 or more types of hearing impairment. The appropriate device should be chosen based on the type of hearing loss present. Central hearing loss can result from a problem of transmission of the stimuli in the brain, an inability to decode and sort signals received from one or both ears, or a failure in the transmission of sounds from one hemisphere of the brain to the other. Causes of this could include brain tumors, vascular changes that suddenly deprive the middle ear of its blood supply, and cerebrovascular accidents. The sense of balance and equilibrium is governed by the vestibular system in the inner ear. Increases in fluid pressure in the inner ear, inflammations, and vascular disorders that interrupt blood supply to the cochlea can produce dizziness, loss of balance, and nausea and vomiting. Benign paroxysmal positional vertigo, also known as BPPV, is the most common cause of vertigo, and it occurs as a result of small calcium crystals in the inner ear. Meniere's disease and labyrinthitis will also cause vertigo. A patient who experiences dizziness and positional vertigo should be cautioned to avoid suddenly turning the head or making other movements that would aggravate the vertigo. Typically, patients with this type of vertigo will feel that the room is spinning around during an attack, and then emotion will exacerbate that sensation. While the patient is having an attack of vertigo, they should lie in bed and remain as motionless as possible. These attacks could last from a few minutes to hours. Medications to reduce motion sickness and nausea are typically given every 3 to 4 hours or on a preventative basis before the patient's symptoms become severe. A series of head movements that can be done at home include Epley maneuver, Brandt-Daroff exercise, Foster maneuver, or the Semont maneuver could all be helpful in moving the calcium crystals that cause BPPV. When increased fluid pressure in the inner ear is suspected as the cause of dizziness, the healthcare provider could order a low-sodium diet and limit fluid intake. Tobacco is vasoconstrictive, and it can affect the blood supply to the inner ear and nerves. Stress can affect the frequency of attacks and vertigo in patients with inner ear disorders. Ringing, buzzing, or other continuous noise in the ear can be mildly annoying or so severe that it interferes with activities of daily living and prevents the patient from getting sufficient sleep and rest. Continuous cases are typically caused by an underlying medical problem. Common causes of tinnitus include presbycusis. This is a hearing loss associated with age, constant exposure to loud environmental noise, inflammation and infection in the ear, otosclerosis, Meniere disease, and labyrinthitis. Tinnitus could be one of the first symptoms produced by an ototoxic drug. Symptoms of tinnitus are subjective, and diagnosis will be by patient history. Medical treatment begins with efforts to determine the underlying cause and then treat it. The goal of treatment is to lessen the impact rather than to eliminate the problem. Less traditional measures that have varying degrees of success include biofeedback training and masking. Carbamazepine has been shown beneficial for those with tapping pulsatile tinnitus. Benzodiazepines like Valium or Librium will also seem to help some people. Biofeedback training is especially helpful in those cases in which emotional stress and anxiety are believed to be the underlying cause of tinnitus. Masking simply provides a low-level noise to block out or mask the head noise heard by the person complaining of tinnitus. Some examples would include the sounds of nature or white noise. The therapeutic effect of masking is highly individualized. Some people will find instant relief, some will have partial abatement of the head noise, and some will not benefit from the attempts to mask the sounds of tinnitus. Specific measures to rehabilitate a patient with hearing loss will depend on the age and the aptitude of the patient. Only about 60% of sounds in the English language can be identified by watching the lips. Communication by lip reading is enhanced by other nonverbal cues, like facial expressions and hand gestures. Learning to lip read is difficult. It requires at least average intelligence, exceptional language skills, excellent eyesight, and much persistence and patience. American Sign Language, or ASL, is the third most commonly used language in the United States. An evaluation by a reputable audiologist could lead to a prescription for a hearing aid designed to provide the best possible improvement of hearing. Hearing aids will not restore normal hearing, but instead improve hearing. Newer digital types can amplify tones needed while masking other levels of noise. The design of a hearing aid will vary. Some can be worn in the ear, others worn behind the ear, and still others are built into the frame of the eyeglasses. Persons with binatural hearing loss, where both ears are affected, must wear a hearing aid in each ear. The hearing aid should not be handled roughly or dropped. The ear mold, if removable, can be cleaned with soap and water, but the other parts of the aid should not get wet. When an incapacitated patient has a hearing aid, you will be responsible for the security of their hearing aid. Implantable middle ear devices have become available for those with limited success at conventional hearing aids and have severe sensorineural hearing loss. These could be indicated for adults 18 years or older. Cochlear implants are available for patients with moderate to severe bilateral or unilateral sensorineural hearing loss. This device is a small computer that changes spoken words into electrical impulses that are then transmitted via an implanted coil to the nerve endings in the cochlea. A speech therapist will work with the patient once the cochlear implant is in place, and most patients will adapt to this within 1 to 2 months. Many devices on the market will use hearing aid technology. These devices can assist people to hear telephone conversations, TV, and sound systems like those in a church or a theater. A telecommunication device for the deaf, known as TDD, is available. This is a combination typewriter and telephone and can be used to communicate with someone else who has a TDD or to call a relay center that will then communicate the message back to the intended person. Hearing ear dogs are trained to alert their owners to particular sounds and can keep their owners safe whenever around traffic. Infection of the external ear is common and it often occurs in swimmers. Other infections of the skin can affect the external ear. A moist environment or disruption of the skin from trauma can provide a place for pathogens to grow. If too much cerumen is present, there can be retention of water and debris. This can increase the chance of infection. Pain occurs with the infection. Itchiness of the ear canal and discharge of liquid or pus can occur. If swelling occurs in the ear canal, hearing can be impaired because the sound waves will not be able to reach the tympanic membrane. The swelling can produce a feeling of ear fullness or pressure. Redness is evident on otoscopic examination, and there may be drainage. Diagnosis is typically based on clinical presentation. The ear canal may be irrigated to remove debris and to improve the effectiveness of topical medications. Antibiotic or antifungal ear drops and ointments are the usual treatment. Drying agents or steroids could also be used. A mild analgesic can help decrease discomfort during healing. Normally, the ear canal will be self-cleaning, but cerumen can occasionally become impacted. Impaction will be diagnosed when the cerumen is causing symptoms or prevents assessment of the ear. Foreign objects like insects or organic matter can also obstruct the canal. Wax softening drops can be used and will work over hours to days. Irrigation of the canal can also be performed to remove it. Extreme caution should be used when irrigating so as not to damage delicate inner ear structures. Otitis media is an inflammation of the middle ear caused by various types of bacteria or viruses. This is mostly seen in infants and young children, but it can occur in adults. It does result in temporary impairment of hearing. The inflammation and infection of otitis media typically follows an upper respiratory infection or trauma to the ear. This could be viral or bacterial in origin. Middle ear inflammation occurs when the eustachian tube that typically drains the area becomes blocked. This obstruction will change the pressure within the middle ear due to the retained fluid. When the infection is sudden in onset and of short duration, it is known as acute otitis media. This pain can be severe. When the infection is repeated, often causing perforation of the eardrum and drainage, it is known as chronic otitis media. Fluid buildup in the middle ear without signs of infection or inflammation is known as otitis media with effusion or serous otitis media. Symptoms could be mild, and they may consist of only a feeling of fullness in the ear and evidence of impaired hearing or tinnitus. There could be pain, high fever, facial paralysis, or severe pain behind the ear. These would be indications of unusual complications. Diagnosis of otitis media will be based on an otoscopic examination showing redness or bulging of the eardrum or pus behind the eardrum. If there is otitis media with fluid behind the eardrum and no acute systemic or local evidence of severe infection, antimicrobials will be withheld. This condition will then be treated conservatively with antihistamines and decongestants. 1/4 of otitis media infections are viral and will resolve without treatment. Severe complications can include a brain abscess or otic meningitis. For repeated episodes of otitis with fluid, or when the fluid will not resorb, a myringotomy, also known as an incision into the eardrum, can be done, and then a ventilating tube will be inserted to drain the excess fluid in the middle ear and to equalize pressure when the eustachian tube is blocked. The procedure is painless and it will take about 15 minutes. The incision will heal within 24 to 72 hours, unless a tube has been placed in the opening. Tubes will typically remain in place for 6 to 18 months before they will be naturally expelled. Acute otitis media occurs when pus-producing bacteria infect the middle ear. Treatment consists of systemic therapy with antibiotics for at least 5 to 7 days, topical therapy with ear drops, and oral analgesics to reduce pain and fever. With repeated episodes, tympanoplasty to repair a ruptured eardrum and damaged ossicles, and sometimes a mastoidectomy could be needed to eliminate all sources of infection and prevent further degeneration of the bone. Keeping the patient comfortable at home, encouraging compliance with the medication regimen, and requesting a return for examination when medication has been finished are the typical nursing actions. Temperature should be taken each day during the course of acute otitis media to track improvement. Infections in the middle ear will always have the potential to spread to the meninges, leading to meningitis, or to the mastoid bone, causing mastoiditis. Patients and families should be taught the signs and symptoms of these disorders to watch for indicating that a more serious condition has developed. Labyrinthitis is an inflammation involving the vestibular portion of the labyrinth in the inner ear. It most commonly occurs due to a viral respiratory infection, but it could be a complication of bacterial meningitis or chronic otitis media. The symptoms include a rapid onset of severe dizziness with nausea and vomiting, as well as an unsteady gait. Nystagmus is also a symptom used in diagnosis. Diagnosis is made from symptoms and by ruling out tumor or other diseases. Treatment will be aimed at treating the primary disease and controlling symptoms. Symptoms of vertigo and its associated nausea and vomiting can be managed with antiemetics, antihistamines, and anticholinergics. Initially, the patient will be kept on bed rest to prevent any fall or injury. Once the symptoms have been controlled, a vestibular rehabilitation program can be implemented to hasten the long-term recovery of balance. Meniere's disease, also known as idiopathic endolymphatic hydrops, occurs most commonly in females. It is most common in those 40 to 60 years of age. Pressure in the labyrinth of the inner ear will result in permanent damage to both the cochlear and vestibular structures. This disorder is typically unilateral. Without knowing a cause, treatment will be symptomatic rather than preventative or curative. The symptoms include intermittent attacks of dizziness, ringing in the ear, and a unilateral sensorineural hearing loss. Poor balance will make walking difficult or impossible. Any sudden movement of the head or eyes during an attack will typically produce severe nausea and vomiting. There is no specific test to diagnose Meniere disease. Diagnostic criteria include 2 spontaneous episodes of vertigo lasting at least 20 minutes, confirmation of sensorineural hearing loss by testing, and tinnitus and/or a reported sensation of fullness in the ear. MRI can be used to rule out central nervous system causes of these symptoms. Treatment of Meniere disease will focus on relieving the symptoms. There is no cure for this condition, although the disorder does disappear spontaneously in some cases. For an acute attack, IV Valium will provide vestibular suppression and nausea control. To control edema and reduce pressure within the inner ear, the patient could be placed on a low-sodium diet. Their fluid intake may be restricted, and diuretics may be ordered. Antihistamines like Dramamine and Meclizine could also act as vestibulosuppressants and help control dizziness. The patient should be kept quiet and in bed to avoid aggravating their symptoms. Care should be taken to avoid increasing irritation by jarring the bed, turning on bright overhead lights, or making loud noises. If attacks continue and are very severe despite medical treatment, the endolymph sac from the inner ear can be removed with microsurgical techniques. But this is typically reserved for medical treatment failures. In the most persistent cases of Meniere disease, the patient will eventually suffer a serious or even total hearing loss, regardless of treatment used. Vestibular rehabilitation therapy, a home-based exercise, can decrease the dizziness and balance problems that result from inner ear damage. If allergy seems to be a factor in the onset of attacks, you should encourage consultation with an allergist to obtain control of these allergens. Dietary changes to limit caffeine, salt, alcohol, and MSG have all been proven helpful for some patients. An acoustic neuroma is a rare, benign tumor on cranial nerve 8 that is typically unilateral. It occurs in 1 in 100,000 people. Symptoms include gradual hearing loss and tinnitus. An unsteady gait, facial numbness, vertigo, and taste disturbances could also be found. This tumor is typically curable with surgery, without recurrence in most patients. Stereotactic radiotherapy could be indicated for select patients. If untreated, acoustic neuroma causes deafness. Treatment is surgical, and nursing care is much the same as for other intracranial surgeries, using measures to decrease intracranial pressure. Otosclerosis is a hereditary degeneration of bone in the inner ear. It occurs twice as often in females and begins during the late teens or early 20s. Otosclerosis is a disease process that causes the formation of excess bone. This causes the footplate of the stapes to be fixed so that it no longer vibrates to transmit sound waves received via the tympanic membrane. The patient will often complain of difficulty hearing the voices of others, yet their own voice will sound unusually loud. Diagnosis is made by otoscopic examination, Rinn and Weber test, and an audiogram. The hearing loss of otosclerosis can sometimes be corrected by using a hearing aid. Microsurgical intervention can restore the air conductive hearing by providing a new movable pathway for these sound waves. During the operation, known as a stapedectomy, the stapes will be removed and then replaced with a prosthetic device. Outpatient surgery with local anesthesia is typical. Hearing improvement may not occur for about 6 weeks. Tympanoplasty can reconstruct the middle ear and improve conductive hearing loss. Postoperative care would involve keeping the patient quiet and flat in bed for 4 hours. The head will be turned so that the affected ear is upmost. Dizziness is likely to occur, so position changes should be accomplished slowly. Coughing and sneezing should be prevented. If they are unavoidable, they should be accomplished with the mouth open to decrease pressure in the ear. For a cochlear implant, an incision will be made behind the ear and the implant placed. An audiologist will work with the patient and family for the initial stimulation and mapping. This will occur 3 to 5 weeks postoperatively. The electrodes that are placed will stimulate the nerve. This then sends impulses to the brain where they can be interpreted as sound. This device does not restore normal hearing, and a period of adjustment will be needed. Postoperatively, pain medication and oral antibiotics will be given. Most ear surgeries are performed as outpatient procedures. Therefore, nursing care will be focused on the immediate preoperative and recovery periods, as well as instructions for home care. Nursing care of patients during the preoperative period will be routine, except for the administration of ear drops or any other special medications. Postoperatively, the patient will typically return with an ear dressing. The full head bandage will be replaced by a headband type covering after the first post-op visit on the day after surgery. Positioning will depend on specific instructions by the healthcare provider. Often the patient will be placed flat in bed and the head should be supported so it doesn't turn from side to side. Watch for any signs of injury to the facial nerve. This would include inability of the patient to close the eyes, wrinkle the forehead, or pucker the lips. Safety precautions like raising the side rails should be taken to prevent injuries from dizziness and loss of balance during the recovery period. Assistance should be provided to prevent falls. Dizziness must pass before the patient attempts to walk. Excessive drainage should be reported to the surgeon. Hearing will typically be impaired immediately after surgery due to the edema or bandages, but it will improve in time. A hearing assessment should be part of any thorough health assessment. Nurses in home and long-term care settings should frequently assess the function of the patient's hearing aid. Hearing ability will change with aging, and reassessment should take place at routine intervals. Assistance dogs can help keep a patient with a hearing impairment safe, both in the home and whenever out and about.